This video contains live surgical footage. Viewer discretion is advised.
Dr. Joe Niamtu, LoveThatFace.com. I'm a cosmetic facial surgeon in Richmond, Virginia. I do surgery from here to here. I don't do boobs, bellies, or butts. I'm a teacher, an author, and a surgeon. So, as everyone knows, deep plane face and neck lift has become extremely popular. It's an advanced procedure. It is not for beginning surgeons, but I've been doing this for a number of years, and I feel that it has really improved my results. And one of the things that really adds to the result, or can add to the result, is reduction of the submandibular glands, which again is a very advanced procedure and not for beginners. So the submandibular glands are two salivary glands we have right here. And some people have large glands or larger glands, and you can't get as nice of a profile without reducing these glands. The reduction that you do really does not cause any permanent problem. And once again, it's an advanced procedure. So I get a lot of requests to show some video on submandibular gland reduction. So I'm going to show you snippets from 7 cases. And if you watch these, they show kind of how I have evolved in this procedure. There's a lot of different ways to do this. So I'll show you all the common ways that I do this in my practice, and I hope you enjoy these videos.
So in deep plane face and neck lift, I start with the deep neck and making a subcutaneous dissection. It's pretty limited compared to older style facelifts where you'll go all the way down the neck almost to the clavicles. And this dissection in this particular case is going to go from there to there where I've outlined, and we're going to leave the so-called patch, which Mike Nyack describes, intact. So now I made a midline incision in the platysma, and I'm dissecting laterally, and I'll do this on both sides. And as we dissect laterally, we'll frequently see the digastric muscle, which if you reduce that, it helps visualize the gland. And if there is bleeding, which you can have a lot, I'll pack that with hemostatic gauze. Here I'm reducing the digastric muscle, which I frequently do in these cases. Now you can see that I have secured the superficial lobe of the gland, and I will begin taking small snips. Okay, and now another case, you can see that I'm dissecting subplatysmal here, and I'm retracting the platysma. This is quite a large gland that absolutely needed to be reduced. And remember, we're just reducing the superficial lobe of the gland. The deep lobe is where the hypoglossal nerve and the lingual nerve are. And once again, this is not a beginner's procedure. So I've dissected the capsule, which is the safe area. You want to stay intracapsular. And the capsule easily dissects, and you can elevate the gland out of the capsule. I'm using a bayonet forceps here to do that. You can use a tonsil clamp or Alice or whatever you want. And I'm starting to expose the gland. We infiltrate it with 2% xylocaine, 1 to 100,000 epinephrine. And once again, these things can really bleed uncontrollably sometimes in rare cases. So you have to be prepared and know what you're doing before you attempt this procedure. After we inject the local anesthetic, we'll let it settle for a while. I've grabbed the base of the gland with a tonsil clamp, and I'm dissecting across the base. You can do this, and you can use a ligature device, which a lot of surgeons do. When I do this now, I usually am doing smaller bits of the gland like I'm showing here, even smaller than this, just to avoid large bleeders. I just kind of chip away at the gland, so to speak. And this gland has all of these lobules, and if you pick these up and dissect them individually or do 1 or 2 at a time, I think that's safer than just doing a cross-cut where you might encounter numerous vessels at one time. So more frequently I do this type of smaller reduction like you see. And once again, you can use, I'm using a Sonoquence radio wave bipolar here. You can use a Bovie, you can use whatever mode you desire, but you have to be very careful not to generate too much heat because you have those nerves. Here's a bleeder, and once again, if you take small bites, when you encounter these bleeders, they're usually pretty controllable. And if you saw me do this now, as you'll see later in this video, I actually irrigate between using the bipolar here. I'll use it, fire it, and then irrigate to cool it. Here's another arterial bleeder, and I think this is pretty common in my experience. Once again, if you're not cross-cutting the entire gland and you're dealing with these bleeders one at a time. Here I'm putting Botox in there. I usually don't do that. I did in this case. Some people do all the time. Some people never do. That's a surgical preference. And again, this was quite a large gland, and you can see the specimen here. And sometimes you can close the capsule or the periglandular tissue, and sometimes you can't. And then after you reduce the gland, you can see my platysma once again. Then you can remove any excess platysma and do your platysmoplasty as you usually do. So that's one way to do this. Okay, so here is another case, and I'm going to show you a pretty significant arterial bleeder in this case. So I'm taking smaller bites of the gland here, the kind of individual lobules or several lobules at a time, and if I get any oozing, I will cauterize it using either the Bovie or in this case Sonoquence radio wave, which has the same effect basically. And again, a lot of surgeons use the ligature where you can cross clamp with that particular device. So taking smaller portions of the superficial lobe, and then boom, there you go. There's a good bleeder right there. It went almost over my shoulder. And these things can fill up quickly, so you have to be prepared to deal with this bleeding. And it can be a little bit overwhelming at first. If that happens, you need to put the table in reverse Trendelenburg and pack this with hemostatic gauze or cold saline and go back at it and take a deep breath and achieve hemostasis. So once again, I'm reducing small pieces of the superficial lobe. And once again, you want to irrigate and control your lateral thermal spread because you have the hypoglossal and lingual nerves there, and these coagulation devices can generate a lot of heat. So now my gland is no longer hanging below the inferior border of the mandible. You don't need to reduce glands if they're not protruding, or usually if they're not hanging below the inferior border of the mandible. So here's the contralateral side. I'm doing the similar procedure, reducing small portions of the superficial lobe. Here I guess I got a little bit more brave and I cross clamp this and reducing the base. And always remember, I know I keep saying it, but always remember that lateral thermal damage that can spread. So you're watching me just reduce small portions of the lobe until the gland no longer is ptotic. But you have to see if the gland is ptotic preoperatively because while the patient's lying down, the glands retract. So it's very, very important to check the gland ptosis or prominence in the upright position before surgery. And now we're completing this side.
We're going to be reducing the left submandibular gland using a Sonoquence radio wave spatula tip, and we reduce the superior lobe. And if we do encounter a bleeding perforator, as you can see here, then we'll use the bipolar forceps. And these glands are extremely vascular, so you really have to stay on top of your hemostasis. And what we do then is make sure that we have a dry field and go back with the spatula electrode. And we are grasping the gland with the tonsil clamp to lift it out of the surgical field and continuing our sectioning of the superior lobe until we have that removed. And again, we want to make sure we have hemostasis and we want to seal the base of the gland.
Okay, now on this particular case, where there's my platysma, and you can see I'm subplatysmal, and you'll identify the gland in the inferior lateral part of your dissection, and it's yellowish or whitish, and it kind of shows through the capsule. And once you enter the capsule, then you begin your intracapsular dissection. These vessels and salivary ductules run pretty much vertical. So you just want to lift your gland out and dissect it and gently remove the excess if it is hanging below the mandibular border. Now remember, this is very vascular. These branches, the facial artery and facial vein actually cross your dissection frequently, and you have these perforators from the sublingual and submandibular vessels as well. So there's a lot of potential bleeding here. And if you stay in the capsule, that is your safe plane, and you just very easily dissect this. It's kind of like blepharoplasty. You don't want to put too much traction on the gland in case you were to rupture a vessel and the gland would retract. Then you're having a problem. So we're only reducing the superficial lobe, and I'm attempting to grab it with the skin hook and just complete this intracapsular dissection. When you're in the capsule, you're safe from the marginal mandibular nerve, which is about 37 millimeters superior to this area, close to the mandibular border. So the key here is being able to take away ptotic gland when indicated and do it safely. Protect the lingual and hypoglossal nerves and the marginal mandibular nerve, as well as being able to control any bleeding. And I'm securing part of the superficial lobe and using the radio wave, and you can use a Bovie or whatever. I'm also irrigating to every time I activate the bipolar, I'll irrigate that just to make sure I'm not spreading lateral thermal damage, because these things can really get hot and heat up the tissue. And just continuing to take little bites and control any bleeding on the way. Some people say that you can certainly have dry mouth after reducing this gland. The submandibular glands produce 70% of the saliva at rest, but when stimulated, i.e. when you're eating or thinking about eating, your parotid glands take over, and it's the reverse. They produce 70% of your saliva, and the submandibular gland produces 30%. So once I have the gland removed enough, I'll gently cauterize the base to seal this to discourage sialocele, which you will see that from time to time if you're doing gland reduction. And now I can take my platysma, reduce the excess on both sides, and perform my platysmoplasty after I've reduced the glands and the anterior belly of the digastric, which I usually do in these cases. I'm going to grab the gland and 3, stop. There you go. 1, 2, 3, stop.
Good.
1, 2, 3, stop. Got it?
Yep.
All right, stop. Right. Okay, now, and we're going to go to the base here.
And finally, in this case, which is an older case, I'm using a tonsil snare to clamp the gland for hemostasis. And it also elevates into the surgical field. I'm using the radio wave spatula tip to section the gland. If I were doing this today, I would go in smaller pieces. I've actually submitted this for publication. There's the superficial lobe removed, and the contralateral side, same thing. And then I am cauterizing the base for bleeding. And speaking of bleeding, here's a case, not the same case, but where have a pretty significant arterial pumper, and that base can fill up very quickly, so you have to be ready to control bleeding. The next case that I'm going to show you is one of the first submandibular gland videos that I posted on YouTube, I think around 2017. This approach is from the older style facelifts with extended dissections. With today's deep plane technique, as everyone knows, the subcutaneous dissection is much more conservative, and the flap is too small to access the gland. For surgeons performing more extensive post-auricular dissection, the gland can still be reduced in this manner, and I have friends that this is their preferred route. However, I do it solely now with a submental incision and a subplatysmal dissection, usually reducing the anterior belly, the digastric, to better view the gland, and reducing it as I showed in these other videos. So this is a bit historic right here.
So we're in the midst of a facelift on this patient. We pull everything back. Our skin looks great and our neck looks great, but we have this bulge here which represents a ptotic submandibular gland, and there's a number of ways to deal with it, and you can try to put sutures over it to push it back. You can try and suspend it. In this case, we are going to open the capsule and actually resect some of the superficial lobe there intracapsularly, and we'll show you that in a second.
Good.
So we're making an incision here over the capsule, and if we dissect this, we'll come back and you can see part of the gland sticking out right here. We'll get in there and dissect this. So when I spread this, you can see that there is one of the lobes of the submandibular gland coming out of the capsule. So we're not going to just cut across there with the scissors. We're going to do some soft tissue blunt dissection, and then probably take a bipolar forceps and dissect that out. But that is the gland. Now let's come out, everybody, and let's drop this, and you can see the bigger bulge now that the gland is exposed. So what we're doing is very carefully removing this, and the staff is and the staff is watching for any nerve movement. And if you stay in the capsule, you're pretty safe. There are some blood vessels. So let's take this out and drop everything. And so this is where it was, and we may take off a little bit more, and then we have to close that. I closed the incision over the capsule. So we're grabbing the capsule and the surrounding fascia, and I like to get a good tight primary closure here, because you can have a sialocele with these. So we're going to put 3 or 4 or 5 sutures across that and close that. Now, okay, so we have closed everything, and you can't even tell we were there. And again, you have branches of the facial nerve. You have the marginal mandibular nerve. You have the hypoglossal nerve that's pretty deep, and you have the lingual branch of the facial artery. And depending on what approach you're taking here, you have to worry about the facial artery and vein. So there's some significant anatomy, and now we'll come back and show you what we've achieved. So this is the area where we had the big bulge, and there's still some swelling, but that'll go down and definitely is more smooth and confluent than when we had the big submandibular bulge. And here is the excised portion of the gland. Now that's not the entire gland, that's probably about a third of it, but that was enough to reduce that bulge. So that's how we deal with, or one way to deal with the submandibular gland during cervical facial oritidectomy. I'm Dr. Joe Niamtu, lovethatface.com. So if you're a surgeon and you like what you saw here, I have a full online for purchase video series on my website, lovethatface.com, under physician education, or you can get there by going to cosmeticsurgeryeducation.com. And I have all 4K video of all the common cosmetic facial procedures recorded and narrated, similar to what you have just seen. So if you're interested, take a look at that. And we also have a course each year at our office in March, and that information is on the same websites. I'm Dr. Joe Niamtu, lovethatface.com.